And the topic is the tip of the iceberg because it's really what we know, and there is way more that we don't know than what we do know. First, let's start by seeing how many of you take vitamins. Okay, a large number. And it's an important topic when it comes to POTS and when it comes to neurologic disorders in general. So we'll start by first discussing what causes POTS. Proposed theories, some have more evidence than others, but one, as some of you know, or probably all of you know, is autoimmune basis. We know that because we found antibodies in patients with POTS, specifically alpha-1 antibody, beta-2, beta-1, muscarinic and ganglionic acetylcholine receptor antibody. We also know that angiotensin II type 1 receptor has been also identified in the serum of patients with POTS. Subsequently, about 50% of patients with POTS also have small fiber neuropathy. There is an association. And quite a few patients also have mast cell activation syndrome. They may not be the cause, but they may be comorbid conditions tying into dysautonomia. One of the major mechanisms in POTS and other disorders of the orthostatic intolerance is cerebral hypoperfusion. Another common mechanism is hypovolemia by impaired renin-angiotensin-aldosterone system, and we have studies from Vanderbilt to show that. At the root of postural tachycardia syndrome is sympathetic overactivity. Increased parasympathetic nervous system is at the root of postural tachycardia syndrome. And then we have this in bold, impaired metabolism and energy production. And that's one of the less studied mechanisms that hopefully will be explored in the future. Some believe that dysautonomia is a pro-inflammatory state because in certain patient populations, specifically in those with chronic fatigue syndrome, increased cytokine production or pro-inflammatory cytokines have been noted. And then there are others who believe that dysautonomia is really a syndrome of neuroinflammation. Again, this is a proposed theory, but we have some evidence from studies on chronic fatigue syndrome patients and fibromyalgia patients to show that their brain is really different in terms of functional MRI changes and also neurochemistry. Neurochemical abnormalities. We're not there yet, but this is going to trend into that direction of neuroinflammation. We'll start by reviewing vitamins and its history. So the word vitamin was coined in 1911 by a biochemist, Casimir Funk, from 1880. He lived from 1884 to 1967. And he studied at the Lister Institute in London. He isolated a substance that prevented nerve inflammation in chickens raised on a diet deficient in that substance. And he named that substance Thiamine because he believed it was necessary to life and it was a chemical amine. The letters A, B, C were assigned to the vitamins in order of their discovery, with the one exception being K for coagulation, which was identified by a Danish researcher, Henrik Dam. Which vitamins are there? Well, there is a bunch. One is vitamin A, retinol, and those are the keratin compounds responsible for transmitting light in the retina. As it is commonly known, deficiency in vitamin A may lead to night blindness. Beta-carotene is an antioxidant which protects cells against oxidation damage that can lead to cancer. and it can be converted as needed to vitamin A. Food sources of beta-carotene include vegetables, carrots, sweet potatoes, leafy green vegetables, and fruits, cantaloupes and apricots, everything that's orange, essentially. Excessive carotene in the diet can temporarily result in yellow skin, a condition called carotenemia. And if you've had babies and fed them sweet potato and carrots, you know they turn a little yellow. Vitamin B1 thiamine is the kind of a vitamin we'll be talking about extensively today. It's a coenzyme in body metabolism. Traditionally, classically, deficiency leads to beriberi, a disease of the heart and nervous system. We'll talk about that later a little bit. Vitamin B2, riboflavin, is essential for reactions of coenzymes, and deficiency causes inflammation of mucosa in the mouth and skin. Vitamin B3, niacin, essential part of coenzymes of body metabolism. Deficiency also causes skin lesions in the skin, vagina, rectum, as well as other symptoms like cognitive slowing. Vitamin B6 is a pyridoxine, and it's an important cofactor. Again, deficiency leads to inflammation of the mucosa, skin, mouth, nausea, vomiting, dizziness, weakness, and anemia. Vitamin B6 is an interesting vitamin. It's the only vitamin that can cause neuropathy when it's high, when the level is high, and the only one that causes neuropathy when the level is low. So it causes neuropathy when there is too much of B6 in your body or too little. Folic acid is important for DNA synthesis. Folic acid deficiency leads to anemia and leads to neural tube defects in pregnant women, which is why pregnant women take folic acid, and our food is fortified with folic acid. Vitamin B12, very important. Everyone is getting this tested because it's a very important vitamin in neurology. But of course, it also leads to anemia when deficient, and specifically pernicious anemia. Vitamin C is your ascorbic acid, and it's important in the synthesis of collagen, which is why oftentimes in Ehlers-Danlos you see recommendations to supplement vitamin C. It also has mast cell stabilizing properties, specifically slow release. Vitamin D is a steroid vitamin which promotes absorption and metabolism of calcium and phosphorus. Of course, under normal conditions of sunlight, supposedly you don't need any dietary supplementation, but I'm convinced that there are people who are unable to properly absorb and metabolize that vitamin, which is why we see vitamin D deficiency in people living in Florida, for example. And it leads to rickets in children and osteomalacia in adults. It's important for your bones too. Vitamin E, again, deficiency leads to anemia. Back a few years ago, vitamin E was something we supplemented supposedly to slow down the cognitive decline in older people. We're not sure if that's actually effective, but because we don't have that much, we often recommend vitamin E 400 international units for older people with cognitive complaints. Vitamin K, an essential factor in the formation of blood clotting, and deficiency can lead to abnormal bleeding. So, is there a topic of vitamin deficiencies in POTS? Well, there is, because some studies, just a few that I will review now, have shown that our patients with POTS tend to be deficient in vitamin B12, in iron, and vitamin D as the most common ones. So in one study by Owner in 2014, the authors found significantly lower levels of vitamin B12 in patients. And the patients included a cohort of 125 adolescents with spots. And they compared it to healthy controls. And you see 47.2% of POTS patients had deficiency versus only 18% of controls. And the p-value is statistically significant. Another study was done, a smaller study of 32 adolescents with spots, and they separated boys and girls. And once again, they found in this study that low iron stores were prevalent in patients with spots. Iron deficiency was prevalent as well. And if you take a look at the boys, specifically anemia, 43% of POTS boys had anemia versus only 0.1% of healthy boys. So there is clearly a relationship. And the reason why they separated is because girls often have iron deficiency and anemia from periods. Another study in 2011 involved 188 adolescents. This time was fatigue and orthostatic intolerance, not POTS, but that's the group, that we're dealing with often. Once again, in that cohort, 47% had iron deficiency with low iron stores. 22% had iron deficiency, and also in that study, they know that 22% had low vitamin D in the sample of patients compared to the control, less than 20, which is quite low. And in that study, they concluded that vitamin D deficiency was associated with orthostatic intolerance. Vitamin B1, well, as I said before, we'll be talking about that. Vitamin B1 or thiamine is a water-soluble vitamin that plays a vital role in metabolism, growth, development, cellular function. And of course, it's very important for neurologic peripheral nervous system and central nervous system. It is water-soluble, and very little is stored, which means that only after 14 days of not consuming enough B1, you can become deficient. And that's important for our patients who often have nausea and gastroparesis and food sensitivities and problems with absorption. It doesn't take that long to become B1 deficient. And as we see later, symptoms of B1 deficiency closely parallel symptoms of POTS, and then you really don't know what's causing what. Is it POTS? Is it POTS worsening? Is it B1 deficiency? Which is why we're doing this talk, because it's important to test for it. Dietary sources are necessary. So again, if you're not consuming enough B1, you will be deficient fairly fast. What are the sources? It's beef, milk, nuts, seeds, whole grains. And in our country and in all of the industrialized countries, flour and rice are often enriched with thiamine, which means if you eat a gluten-free diet, but if you eat rice, you should be getting vitamin B1. Of course, if you eat no grains, right? No grains, no meat, no dairy, as you see, you can certainly become deficient. Most commonly in the United States, a vitamin B1 deficiency isn't associated with malnutrition, but is associated with alcoholism and malnutrition for medical reasons. Patients with eating disorders can become deficient, and also pregnant women with severe vomiting and nausea may become deficient as well. And another population that emerged in the past 30 years is those who have done bariatric surgery and became deficient not only of B1 but of many other vitamins and minerals. So, what does vitamin B1 deficiency cause? Well, in severe cases, it causes significant cardiovascular and neurologic complications. Most severe cases will include those with heart failure from B1 deficiency. And then also, neurologically, Patients may end up with Wernicke's encephalopathy, which is a triad in neurology. It's a common question on all of the boards. It's a trial of encephalopathy, ataxic gait, and oculomotor dysfunction. Wernicke's commonly occur in people with alcoholism or severe malnutrition from not being able to eat food. MRI of the brain can show hyperintensities in the mammillary bodies, thalamus, and hypothalamus. This is for us neurologists to know. Korsakoff syndrome is a chronic memory disorder that includes psychosis. Because if you're chronically deficient in B1, you may develop psychiatric illness that looks like psychosis, schizophrenia, bipolar, but it's actually B1 deficiency. Again, it's important to check. And now we come to this point of what is mild marginal deficiency. Well, marginal deficiency is described when thiamine stores are sufficiently depleted to affect the patient and produce some symptoms, and the laboratory tests show some low levels, but not enough to create the classical syndromes that I just talked about, heart failure, Wernicke's, and Korsakoff. And marginal deficiency may give rise to many symptoms, and they're called vague. And I outline them and I underline certain symptoms just to show how confusing this can be. So symptoms of mild B1 deficiency are mental fatigue, brain fog, emotional lability, paresthesias, which is numbness and tingling in your extremities or face, chest pain, tachycardia, generalized weakness, myalgias, back pain, nausea, vomiting, and decreased ability to perform physical activity or work. Does this remind you of something? And as I said, that's why patients may start with spots, with nausea, they're very sick, they don't eat enough calories or they don't eat the right food, and they become sicker. And if you're not aware that there may be a vitamin deficiency, you may assume that this is spots worsening, whereas in fact, it may be a second problem developing. And we'll talk about it in a second as well. So years ago, I had a patient in her early 20s who came to my clinic very sick. Her mother was a nurse. They live in a small town near mine. And her symptoms were tachycardia, chest pain, dizziness, anxiety, insomnia, and nausea. Of course, in that small town, doctors thought it was anxiety. She did end up on a psychiatric unit where they were giving her benzodiazepines, didn't work. Antidepressants made things worse because a lot of our patients are unable to tolerate antidepressants. So by the time she came to me, she was very sick and she lost a lot of weight. So we started from the beginning where I checked all of her autoimmune markers, inflammatory, and vitamins. Interestingly, she had a slightly low vitamin B1. Now, to give you an idea of how sick she was, she would call my office almost every day. And when she was in my office, she had episodes right in front of me asking to call an ambulance. She was in bad shape. Her blood pressure, heart rate were all over the place. And no medications was helpful enough. So when I saw this vitamin B1 deficiency in her, of course, I supplemented. And then I forgot, I haven't heard from her for a few days, and I was thinking, well, her follow-up is coming up. It came up a few weeks later, and when I saw her, she said, miraculously, almost all of her symptoms were gone. She felt that way just after a few days of taking vitamin B1. Now, when that happens, when a patient tells me I had miraculous recovery, of course, I have to assess, was there a psychological component? Is this a placebo effect? So we tried to actually stop B1 a few times, and the symptoms would worsen. So we decided to keep her on it. And from that, I decided to do a short case series because I checked B1 in all of my patients to see is there anyone else who is deficient, and do they respond so well? So this paper came out of that patient. And the objective was to determine the prevalence of vitamin B1 deficiency and assess response to vitamin B1 supplementation in the deficient patients. We had a chart review of 65 consecutive patients. 59 were women, 6 were men, ages were 13 to 54 years old. All of them met diagnostic criteria for POTS and were evaluated by me, so it was easy for me to go back in my records. All of them had diagnostic workup that included vitamin B1 and other vitamins as part of Quest diagnostics, so easy access. And when we found a B1 deficiency on whole blood vitamin B1 test, not serum, they received thiamine hydrochloride at 100 milligrams daily for 4 weeks. And then they came to the office for a follow-up. So it was a fairly easy study to do. And my research assistant created these nice visuals, and this is the method. All of them satisfied criteria for POTS by a tilt table test with a heart rate increase of at least 30 beats per minute within 10 minutes of tilt. They had to have symptoms for at least 6 months, symptoms of orthostatic intolerance. The test was performed by liquid chromatography, where they analyzed thiamine diphosphate to determine nutritional status and the body's stores. And we use whole blood vitamin B1 test rather than serum because this is more accurately represents whole body stores. Supplementation, easy. It was just over-the-counter, any brand thiamine hydrochloride, 100 milligrams once a day for 4 weeks. And the outcomes were self-reporting of symptoms and also rechecking the levels. These are the results. So out of that 65 consecutive patients, 4 had mild vitamin B1 deficiency. And as you see, all of the numbers are in the 70s, so they're not crazy abnormal, because the normal range is 78 to 185. So just marginally, this patient 1, which is the patient I told you about, had only 75, just by a few. Perhaps others may have thought that this was just fine and no problem, but clearly it was very significant and relevant to her case. And then we had the other 3 patients. Now, it was only in that patient, in the first patient, where miraculous improvement occurred a few years ago. The other 3 did not notice any change when B1 was supplemented. But since then, I have had a few others who certainly had significant improvement in their symptoms, were able to return to work after supplementing and didn't want to stop. The second they stopped, the symptoms got worse. So I have a few more, more recently, and they were not included in this case series from a few years ago. So 6%, right, 4 patients tested borderline low on B1, and only 1 of them had this significant recovery, and these are just nice tables that my research assistant did. The conclusion was that we found a 6% prevalence of thiamine deficiency in our patients with spots. Of course, over the years, the cohort is no longer 65. In more than 500 patients that I can recall, I think 6% is probably an accurate number. I haven't seen it in more. I think a small subset is going to be deficient in thiamine. Our participants, all of the 4 patients, had no risk factors for thiamine deficiency. They were not alcohol users. They had no significant GI disorders. They had no celiac or inflammatory bowel disease or GI cancers. And they had no history of eating disorders or bariatric surgery. I think it's very important because we stratify by risks, and they had no risk except for POTS and, of course, nausea, and maybe someone had gastroparesis, but it wasn't anything pronounced. So how would B1 deficiency potentially cause POTS, if that's a cause. We have substantial evidence that indicates that thiamine modulates release of acetylcholine. So the synaptic transmission, which is how the nerves are communicate in the peripheral and in the central nervous system, this would be affected. And previously, thiamine deficiency was linked to central muscarinic cholinergic lesion affecting neuronal transmission at the peripheral ganglia. Exactly what I just said, that the way the nerves are communicating is through acetylcholine. And if thiamine deficiency leads to decrease in acetylcholine release, then it's natural to conclude that it would modulate the parasympathetic and sympathetic nervous system. And thiamine deficiency also can cause vascular dysfunction by reduction of nitric oxide production, and nitric oxide is also very important in POTS. Dr. Stewart studies it. So there is that angle, both synaptic neuronal transmission and vascular dysfunction. And together, these findings indicate that thiamine helps modulate the autonomic nervous system and conceivably could be, I say could be because it's a hypothesis, we haven't proven that, it could be a factor in the pathophysiology of POTS in a small subset of patients. We really need to have large studies, placebo control, to determine the true prevalence of vitamin B1 deficiency. And also, it would be nice to know who and when and how they respond to B1 supplementation on a large scale. This was a small chart review. To remind everyone, if you ever want to know what the chemical structure of thiamine is, thiamine pyrophosphate, or TPP, is the active form, okay? And it's synthesized from ATP, which is the energy to AMP. So that's the active form right here. Where is thiamine important? In the Krebs cycle. If you ever took chemistry, biochemistry, you recall this complex Krebs cycle, there it is. And thiamine is important to convert lactate, which is a product of anaerobic metabolism, to acetyl-CoA that goes into the Krebs cycle. Thiamine is needed for pyruvate dehydrogenase enzyme to work, and for this alpha ketoglutarate dehydrogenase, two enzymes two enzymes that require thiamine, three enzymes that are important in this pathway. How does thiamine deficiency cause problems? Well, the active thiamine in animals is needed, just like we discussed, for neurotransmitter release, for acetylcholine release. It's needed for thiamine-binding proteins, and it's needed for protein mitochondrial action and chloride channel regulation. So thiamine is needed. And in E. coli bacteria, signaling during amino acid starvation in E. coli is also modulated by thiamine. Response to stress in that bacteria also uses thiamine. So thiamine is an important vitamin for bacteria and us humans. Let's say that thiamine status or thiamine levels are reduced in our body. This will result in decreased acetylcholine, just like we said before. And it will result in elevated blood lactate level, because remember, thiamine is needed to convert lactate into energy, anaerobic to aerobic. That's how energy works in the body. And if you have less of acetylcholine in the brain, what do you get? Well, you can get memory loss, depression, and irritability. Suddenly, you're taking SSRIs. At the nerve ending in the peripheral nervous system, you can get nerve damage, neuropathy. Suddenly, you're taking gabapentin, Dilantin, phenytoin. For your heart, you may end up with heart failure. Suddenly, you're on diuretics. And when you go to that blood lactate elevation, you will see that if you accumulate lactic acid in your body, you will have muscle pain and fatigue, which then perhaps can lead to chronic fatigue syndrome, or it can lead to fibromyalgia and the use of NSAIDs. So this is a hypothetical diagram of what can happen when thiamine status is low on a clinical level. In clinical practice, how do we know that there is a vitamin deficiency, thiamine or many others? Well, we have to suspect it, right? And we have to beware of the overlap between vitamin deficiencies and POTS and fatigue and fibromyalgia and even depression. On physical exam, when you see your doctor, you may have, the doctor may see evidence of neuropathy, skin lesions, hair loss, murmur, and other things that can suggest. When you are in the high-risk population, meaning that you have severe GI dysfunction, then your doctor needs to be suspicious. Patients with gastroparesis, rapid gastric emptying, which are patients with spots, diarrhea, nausea, abdominal pain, lack of appetite, those are the ones that we have to test for. And then we have mast cell patients. Of course, with multiple food sensitivities, reactions, and allergies, there is less to consume. Just yesterday, a young patient with a mast cell syndrome tested also marginally low, so we're going to supplement that. If you have Ehlers-Danlos syndrome, you are prone to dysmotility of the gastrointestinal tract. You can have small intestinal bacterial overgrowth that may alter motility and absorption. If you're on a vegetarian diet and grain-free diet, you can get B1 deficiency. And of course, if you had gastric bypass surgery for weight loss, or if you have anorexia, or if you lost weight rapidly, we also have to check your vitamin status. And of course, if you have celiac disease, Crohn's, ulcerative colitis, or GI cancers, that buys you a vitamin check. And we have that testing available. We commonly test for B12, B1, B6, E, D, C, A, ferritin, copper, magnesium, homocysteine, folate, and CoQ10. We can test for those, and we should. How do we interpret? Well, as you know, every lab has its own range, so we have to be aware. We have to be aware what's deficiency versus insufficiency. And what is low normal level? Some doctors say, oh, your B12 was only 250. Well, the normal is 220 to 1200. So technically you're in the normal range, but you are already deficient because I call it borderline low. Significance of low level despite supplementation. Significance of high level despite a lack of supplementation. And genetic test of metabolic pathways is very important, as is pharmacogenetics. Best source of vitamins are natural sources: fruits, vegetables, meats, sun, grain, if you absorb it. Over-the-counter vitamins and supplements are there. So many brands, what to choose from. There are tablets, capsules, powder, there are even transdermal patches. And there are various brands with various concentration of active and inactive ingredients. Beware of excipients and dyes. Pharmacies offer them, but so are very expensively naturopath. Homeopathy did not demonstrate to have any efficacy. And Chinese herbs are known active and inactive ingredients. Common vitamins, minerals, and supplements in patients with spots are sodium chloride, vitamin B12, vitamin D3, vitamin B1, magnesium, CoQ10, iron, caffeine tablets, or coffee, if tolerated, and licorice root. Comorbid conditions. Like I said before, vitamin C is commonly supplemented in EDS. Quercetin is a flavonoid that can stabilize mast cell. Mitochondrial disorders. Patients typically use CoQ10, L-carnitine, creatine, alpha-lipoic acid, vitamin B2, folinic acid, L-arginine, L-citrulline, vitamin C, selenium, zinc, vitamin E. For migraines, especially menstrual migraine, magnesium, B2, feverfew, and CoQ10 can be helpful. Small fiber neuropathy, B-complex vitamins, alpha-lipoic acid can sometimes be utilized. Chronic fatigue syndrome, sometimes patients get lucky and get much better with B12 injections or iron infusions. Muscle and joint pain, sometimes a high dose of vitamin D3, 5,000 to 10,000, can help with pain. For nausea, people use ginger. For depression, sometimes for mild depression, St. John's wort, omega-3 fatty acid, and alpha-linolenic acid can help. If you have insomnia, which is a common problem in our patients, you can try valerian root, which is popular in Europe. Those are drops or capsules and have natural benzo-like properties. Chamomile tea, melatonin, and magnesium. MTHFR, I got to briefly talk about that because Lauren asked me to discuss this. There's a lot of noise about MTHFR. Do we need it? Do we need to know what yours is? Is it important? And the short answer to the slide, which I don't want to take up the time to go through it, the short answer is no. You don't need it. You don't need to know whether your polymorphism is C677T or A12, because if your homocysteine level is normal, that's all you need to know. Now, if it's elevated, as in homocystinemia, that's a different story. Then perhaps. But all of the major bodies, American Congress of Obstetrics and Gynecologists, British Committee on Standards in Hematology, American College of Medical Genetics, 23andMe, they all say no need to test for MTHFR polymorphism. MTHFR polymorphisms have no significant effects on health. It's very important because a lot of the times patients, but this is my MTHFR. If your homocysteine level is normal, then it's right now the way things are, it's irrelevant what your MTHFR is. Other vitamins and supplements, briefly, CoQ10 has some evidence that it reduces fatigue and myalgia in patients with statin-induced fatigue and those with fibromyalgia at high doses. Curcumin, does it reduce inflammation? And in many studies, big studies, there was no evidence to support vitamin and mineral deficiencies that they play a role in chronic fatigue syndrome or fibromyalgia. And then, therefore, insufficient evidence to recommend to supplement them. That's what we know. There is some promise of melatonin in patients with migraine headaches. Future research. Many topics need to be explored. The relationship between vitamin and supplement use in patients with spots. CBD oil is a big and popular agent right now. It's almost a cure for all, but we don't know. We don't know its efficacy in POTS, and we should study it. Metabolic pathways abnormalities in POTS. Are they important? Genetic phenotypes, possible association between certain polymorphisms and POTS. And then also we need to know HLA subtypes in POTS. Personalized medicine, pharmacogenomics, and adversomics are very important future fields that will tell us how each individual is metabolizing drugs, why some patients have adverse events from vaccines and why most people don't. So that's the future direction there. These are the references that I used, and this is POTS, the elephant in the room.
Hi. Mm-hmm. Would there be any harm in taking a B1 supplement before getting tested?
I prefer testing because this will tell us, are you in one of those deficient states or normal?
Yeah.
I don't think there is harm at all, but it's good to know. It's good to know if that's what we're dealing with. Because, see, if you are deficient, then maybe the regimen of 100 milligrams isn't going to be enough. Maybe you'll need more. Maybe you'll need longer. So this information of testing is very important.
Thanks.
Is it possible to not be deficient, but not, or to not show a deficiency on a test, but not actually metabolize the vitamins?
It's a very good question. Some people feel that the testing we have doesn't adequately represent your intracellular stores. And that's why perhaps trying on a trial basis, but also testing. If some people have high B6 levels that I see, they take no supplementation. So obviously taking more B6 wouldn't be a good idea in this case.
Okay, thank you. And a follow-on question to that is there any harm in taking the supplements that you recommended for the POTS patients without being, I know you mentioned like without being tested if you weren't tested on all of them?
And just like I said, if you happen to be high on B6 or B12, taking more isn't something good. I actually ask patients to stop taking all of those supplements or vitamins containing the high vitamins that are found in blood.
Okay, thank you.
Hi. Is there a specific type of doctor you would recommend to evaluate the relationship between these, potential deficiencies and what's going on? Because I hear you when you're saying like if my B12 or something used to be 850 and now it's 250, perhaps that's clinically significant for me, but not someone else who's had it riding at 300 their whole life. So I feel that pain of everything coming back normal or just below, and it's like they'd rather send me for 20 tilt table tests and MRIs, and it's like, well, don't you just want to take a couple vials of blood and can I have someone qualified interpret this? And then I'm the one not trying, so I'm just confused as to who I should be going to for something blood related.
A lot of the times neurologists do that. We do check you because, most of those deficiencies cause neuropathy, so we have to check it.
Okay. Thank you.
I actually have two questions. So what if you're positive for antibodies, say for pernicious anemia, but your B12 is actually, it's in the normal, but the low normal range? Does that mean that you do have pernicious anemia, you don't, or do you just treat it?
There are special testing for that, checking out methylmalonic acid and your GI and parietal antibodies and all that.
Okay, and you mentioned menstrual migraines. What is that?
It's when you have headache, when your period starts, or a few days later.
Okay, so it's in your head. I didn't know if it was like abdominal or...
It's a headache when you have your period.
Okay.
We call it menstrual migraine.